The purpose of this lecture is to introduce the image interpreter to some basic terminology when describing abnormalities on chest radiography or CT. Abnormalities on CT or chest X-ray are either the result of too much density or too much lucency. Accurate use of descriptive terms for these findings is essential when interpreting radiological studies, as each term may convey different meanings and bring to light unique differential diagnoses. We will also briefly touch on some of these differential diagnoses as well as some important signs. This is the list of opacities and lucencies that we'll be discussing in this lecture. Let's first start with opacities, those being consolidation, ground glass, atelectasis, septal thickening, reticulation, nodules, and masses. So let's first talk about consolidation. This is the result of a disease that replaces air within the lung with some product of disease, such as blood, pus, water, cells, that then renders the lung solid. This will often obscure vascular markings on chest X-ray, and should the airways be patent, air bronchograms may be present. Sometimes consolidation can be mass-forming. Here on the right, we can see abnormal opacity in the right lung, representing consolidation shaded in green. Also note the streaky lucencies representing air bronchograms running through the area of consolidation. These represent air-filled bronchi running through lung that has been rendered solid. This tells the reader that the abnormality is located within the lung parenchyma. On CT, consolidation appears largely solid, with ill-defined or fluffy borders, noted by the area shaded in green. This is a patient that had an area of lobar consolidation, reflecting a lobar pneumonia. Similar to the chest X-ray, again note the air-filled bronchi running through the area of consolidation, representing air bronchograms. Also notice how the major fissure outlined in green is being displaced posteriorly, having a bulging appearance illustrated by the orange arrows. This is the result of mass effect from pus accumulating within the lungs in this patient with a lobar pneumonia. This is two additional examples of consolidation, though in a diffuse pattern on CT. Both of these patients had ARDS. Notice how some ground glass is also present, predominantly in the lower image, which we'll discuss on an upcoming slide. Causes for consolidation are numerous. The first step is often narrowing the differential diagnosis by whether the consolidation is acute or chronic. Most often the consolidation is acute, with the most common causes being infection, aspiration, ARDS, and pulmonary infarcts from pulmonary emboli, shaded in yellow. Ground glass opacity can result from 4 different processes which are quite different. First, partial filling of alveolar air spaces, similar to consolidation, where consolidation completely fills air spaces. Ground glass opacity is only the partial resulted alveolar airspace filling. Second, interstitial thickening that is too small to resolve by CT, such that all the little lines blend together, creating one hazy opacity as opposed to discrete individual lines. Third, incomplete collapse of alveoli, not filling but collapse. And then lastly, increased blood volume, that is when one portion of the lung is being overperfused. The first two, incomplete alveolar filling and interstitial thickening, is generally what most radiologists attribute ground glass to. It should be noted that this is a finding generally reserved for CT, where this abnormality appears as a hazy increase in lung density that does not distort or obscure bronchovascular markings, which is different than consolidation, as if viewing the CT through scratched or ground glass. In contrast to consolidation, mass effect is never present, or typically not present. An example of ground glass opacity is seen on the right. Let's focus on a particular section for a closer view. Notice how ground glass opacity appears as an area of vague density. There's no mass effect. It does not obscure underlying vasculature that's running through it. This area is shaded in green. Contrast this to the normal lung immediately adjacent to it. Here's another example where we could see patchy areas of ground glass opacity in the left lower lobe in this patient with pneumonia. As we noted on an earlier slide, ground glass opacity is a term that's typically reserved for CT description. However, we can see abnormality on chest X-ray as the result of ground glass opacity, as in this case of PCP pneumonia. Let's take a look at one area for further assessment. Notice how there is vague patchy opacity in the lung. It would be difficult to differentiate ground glass opacity from consolidation in this instance. Many radiologists would simply describe this as patchy opacities instead of committing to ground glass to maintain accuracy. Like consolidation, the causes for ground glass opacity are numerous, and it is best to start with whether it is acute or chronic. Typically, ground glass opacity is acute and can be seen with pulmonary edema, alveolar hemorrhage, some pneumonias, particularly interstitial pneumonias, as well as acute lung injury. It can also be seen in chronic interstitial lung diseases. Going into greater detail is kind of beyond the scope of this talk. Atelectasis is the opposite of consolidation. Atelectasis represents airless lung rather than abnormally filled alveoli. That is, the lung or portions of the lung are underinflated and the parenchyma is normal. Atelectasis can be the result of airway obstruction, passive relaxation or compression, or even fibrosis. We typically describe atelectasis in 3 distinct patterns based on how it appears on imaging. Subsegmental, also known as plate-like or discoid atelectasis, is when a segment or subsegment of the lung is collapsed. This typically appears as band-like opacities in the lung, which are usually well-defined. On the right is a patient's status post-abdominal surgery. Note the low lung volumes from splinting. Also notice these band-like opacities at the lung bases. Let's zoom in on an area for a closer look. Notice these streaky, solid-appearing opacities at the right lung bases that are highlighted in blue. This represents subsegmental atelectasis, a result of passive relaxation from low lung volumes and splinting status post-abdominal surgery. On the right is an example of lobar atelectasis from mucus plugging, shaded in blue. Notice how the minor fissure is retracted up towards the lung apex due to right upper lobe collapse. When a whole lobe collapses, the affected lung typically appears uniformly dense and well marginated, and signs of volume loss such as diaphragm elevation, rib crowding, and fissural movement are usually present. Another example of lobar atelectasis is seen on the CT involving the left upper lobe. In this case, this was the result of essentially obstructing lung cancer. Notice how the major fissure is moved anteriorly and abuts the shaded opacity in blue. This is a coronal image demonstrating left lower lobe lobar atelectasis, the whole lobe being collapsed. Notice how close together the vessels are from the volume loss. Early in training, it may be hard to distinguish atelectasis from consolidation. Some clues that would favor atelectasis over consolidation would be well-defined borders, features of volume loss including low lung volumes, and enhancement. Remember that atelectasis represents normal lung that is airless. Like any other organ, it will enhance, typically much more so than muscle, which can be used as a reference standard. Consolidation, which is typically ill-defined, may have mass effect, will not enhance because it usually represents a filling of alveoli with avascular disease product, such as pus. Here is a summary slide that compares and contrasts the causes and appearances of each of these abnormalities. Feel free to pause the video now if you would like to recap what we had just discussed. Before we discuss the next cause of opacity, septal thickening, we first need to take a minute to review the anatomy of the secondary pulmonary lobule, which is the major architectural unit of the lung. These are hexagonal shaped structures, typically 1 to 2 centimeters in size, containing multiple acini, which are then composed of alveolar sacs. In the center of the pulmonary lobule is the secondary pulmonary artery and the respiratory bronchiole. At the edges are the veins and some lymphatics. Each secondary pulmonary lobule is separated by the intralobular septae, seen here in purple. When these intralobular septae become thickened due to tumor or water, we can see septal thickening or septal lines on chest X-ray or CT. This is a zoomed in CT image at the far right lung apex. Notice the smooth white lines outlined in purple. These white lines running through the lung represent areas of intralobular smooth septal thickening. Another CT image seen more inferiorly towards the right lung base with a similar appearance, where again we can note smooth intralobular septal thickening, these smooth white lines which we can see outlined in purple here in this patient with interstitial pulmonary edema. Again, this is a case of smooth intralobular septal thickening. We can see thickening of the secondary pulmonary lobule. In this case, it was due to water. In this patient, we again note septal thickening highlighted in purple. Also note how the septae appear somewhat beaded in appearance, as if there's very small nodules along them. Note these small areas of nodular thickening here. This represents what we call nodular septal thickening. This is a little bit different than what we saw with the smooth septal thickening, and this patient had lymphangitic carcinomatosis from breast cancer, that is, tumor within the lymphatics within the lung. Also notice the enlargement within the mediastinum in here. This represents lymph node metastasis. Identifying septal thickening on chest x-ray is often difficult when first starting. This patient does have a mild degree of septal thickening, though it may be difficult to see, so we'll have to zoom in on one particular area, this area in the left lung here. Notice that there are small, short, smooth lines in the periphery of the lung, which you can see highlighted in blue. Notice these lines out in the periphery of the lung here. In addition, we could also see that there are some longer lines highlighted in green emanating from the more central aspects of the lungs. These lines reflect curly lines, the shorter, more peripheral ones being curly B lines, and the longer, more central ones being curly A lines. Both represent the exact same process, which is intralobular septal thickening in this patient with a mild degree of interstitial pulmonary edema from congestive heart failure. Differential diagnosis for septal thickening includes some common as well as unusual disorders. By far, the two most common causes of septal thickening are pulmonary edema and lymphangitic tumor. Reticulation is also a form of interstitial thickening like septal thickening. Reticulation represents a collection of innumerable small linear opacities that by summation produce an appearance resembling a net. However, the appearance is somewhat different than what we saw for smooth septal thickening. On CT, these appear as short, choppy lines that can be fine or coarse in appearance and are usually peripherally located and somewhat bizarrely shaped. On the right is a zoomed up image of the right lower lobe. Note the coarse appearing lines in the periphery of the lung representing reticulation in red. These are typically associated with pulmonary lung fibrosis. As a result, other features of fibrotic lung diseases may be present, such as traction bronchiectasis or traction bronchioloectasis. Bronchioloectasis representing dilated bronchioles on the periphery of the lung, seen as small black holes or tubes. Notice on the CT image, we can see that there are these areas of branching lucencies that we see within the areas of reticulation, and this area in here, and this area in here, and this area in here. Note these small holes and then these branching lucencies. These represent dilated airways being pulled apart by fibrosis. Also note the reticulation, these short, choppy lines out in the periphery of the lung. Ground glass opacity may also be present, which in the setting of reticulation and traction bronchiectasis is usually the result of microscopic fibrosis, that is, lines too small to resolve by CT. We can see this on the CT on the right-hand side in this patient with scleroderma-related NSIP. Notice again the short, choppy lines out on the periphery of the lung, representing reticulation. Also note these lucencies within the lung, here and here and here, representing traction bronchiectasis, that is airways being pulled apart by the fibrosis. And then you can see that there's these larger confluent areas of ground glass opacity. Again, this is not alveolar filling in this case. This is most likely interstitial thickening from microscopic fibrosis, which is too small to resolve by CT. Reticulation, like septal thickening, may be difficult to first recognize on chest x-ray. This often requires a high degree of scrutiny and zooming in on one particular area for a closer look, which we will do in this case. Notice how the opacity in this lung appears as discrete small lines. They appear coarse and somewhat irregular. This is in contrast to the smooth septal and more discrete lines that we saw in the earlier images in the patient with pulmonary edema. This appearance of numerous tiny irregular lines has been likened to chicken wire or fishnet, which we can see here. I often find reticulation easiest to identify in the lateral view, posteriorly and inferiorly, where fibrotic lung diseases typically occur. Again, note the choppy, bizarrely shaped, innumerable small lines in the posterior and inferior aspects of the lung, particularly over the spine. This again has been likened to the fishnet appearance in a patient with idiopathic pulmonary fibrosis. As mentioned earlier, reticulation is most often associated with fibrosis, though a minority of cases can be reversible. Common fibrosing lung diseases that demonstrate reticulation are idiopathic pulmonary fibrosis, also known as IPF, nonspecific interstitial pneumonia, also known as NSIP, and chronic hypersensitivity pneumonitis, the latter of which is demonstrated on the right-hand CT. We could see again reticulation, traction bronchiectasis, some ground glass opacity, and mosaic perfusion reflecting air trapping, a finding that we will discuss on subsequent slides. This is a case of chronic hypersensitivity pneumonitis. Nodules are defined as rounded or spherical structures seen within the lung. Some arbitrary distinctions have been made by size, and please note that there is some variability with cutoffs regarding these sizes. In general, micronodules are defined being 3 millimeters or less, nodules between 3 to 30 millimeters in size, and masses greater than 3 centimeters. On the right hand CT is a case of numerous micronodules with some highlighted in green. Nodules can be of varying sizes and textures. In this case, the nodules were solid and well defined. This patient had a history of sarcoidosis. Micronodules are further subcategorized into a perilymphatic, random or miliary, and centrolobular distribution, which is a lecture in and of itself and will not be discussed any further on this lecture. This chest X-ray demonstrates numerous nodules, predominantly 1 to 3 centimeters in size, some of which are highlighted in green, in this patient with pulmonary metastatic disease. Note the infused support catheter for chemotherapy as a clue for the cause of these pulmonary nodules. This is the patient's CT correlate, where we notice numerous solid pulmonary nodules, some of which demonstrate surrounding ground glass opacity in this patient with extensive pulmonary metastatic disease. As mentioned on the previous slides, it's important to not only identify the nodules, but then to classify the nodules' texture or density. Nodules can be solid in this case here, as well as what we saw in previous examples. Nodules can also be part solid, that is when there's both a solid and ground glass component, which we see here. Nodules can also be purely ground glass, as seen in the far example on the right-hand side. It's important to accurately describe the texture of nodules, as follow-up recommendations and likely etiologies vary depending on nodule density. At first, one may think that the CT on the right-hand side demonstrates a diffuse ground glass abnormality. That is partly true. However, on closer inspection, we notice that there are numerous small ground glass nodules. These nodules appear to be in a centrolobular distribution rather than confluent ground glass as we had seen in earlier cases of pneumonia. These centrolobular ground glass nodules are characteristic of subacute hypersensitivity pneumonitis in this patient who had birds at home as the exposure allergen. Let's briefly talk about some signs that deal with opacities. The first sign is the halo sign, which represents a solid nodule or a nodular or mass-like area of consolidation with surrounding ground glass opacity. The surrounding ground glass opacity may actually be due to hemorrhage depending on the etiology of the nodule itself. Again, note the solid nodule in the center of the lesion with surrounding ground glass opacity. This again represents a halo sign. Common causes of the halo sign include metastasis, particularly those that are hemorrhagic, such as thyroid, renal, or melanoma, some infections, particularly angioinvasive fungal infection, such as angioinvasive aspergillosis in the setting of neutropenia, and some inflammatory conditions such as granulomatosis with polyangiitis, a vasculitis formerly known as Wegener's granulomatosis. This patient had a history of thyroid cancer and was subsequently diagnosed with a hemorrhagic metastasis in the lung. The opposite of a halo sign is something known as the reverse halo sign. This is also known as an atoll sign. An example is shown on the CT on the right, where we notice peripheral areas of consolidation highlighted in red and a central ground glass opacity highlighted in light red. This appearance has been likened to an atoll, which is a reef island where land represents an area of consolidation. The central lagoon, shallower and lighter water, represents the ground glass, and the surrounding darker ocean, the normal black lung. Again, note the peripheral consolidation and central ground glass opacity, representing the reverse halo sign, also known as the atoll sign. This sign was initially described in the setting of organizing pneumonia, a pattern of lung injury, though it could also be seen in other conditions such as infection, particularly mucormycosis, pulmonary infarcts in the setting of acute PE, and some vasculitides. This patient had started a new medication and had a drug toxicity that manifested as a secondary organizing pneumonia pattern in his lung. This case demonstrates the reverse S sign of Golden, which is the result of both volume loss and mass effect. Notice how the minor fissure is being pulled up. There is volume loss, resulting in the fissure having a concave appearance laterally and being drawn towards the opacity at the right lung apex, which represents the right upper lobe atelectasis. However, also note how the fissure is being pushed inferiorly. This is the result of mass effect from a lesion sitting in the central aspects of the lung, typically a lung cancer. What is happening in this case is that there is a central lung cancer that's compressing the airway, resulting in right upper lobe atelectasis. However, the fissure is not being entirely moved towards the hilum due to the central mass. The shape of the fissure has been likened to a backward S, hence the name reverse S sign. When this sign is seen, the most likely diagnosis and the diagnosis of exclusion is a lung cancer, which unfortunately this patient was subsequently diagnosed with. So that concludes the opacities portions of this talk. We discussed consolidation, ground glass opacity, atelectasis, septal thickening, reticulation, and nodules and masses, as well as some of the differential diagnoses and signs associated with them. So let's now talk about lucencies. These are areas of dark lung that is too lucent. Lucencies that we would be discussing are emphysema, cysts, cavities, honeycombing, and mosaic perfusion. Emphysema is classically associated with smoking and represents areas of lung destruction. This produces holes within the lung parenchyma, which typically manifest as small, round or roundish black circles. It's important to differentiate emphysema from cysts, with emphysema not having any identifiable walls surrounding the lucencies. 3 types of emphysema are classically described, the first being central-lobular, which we see on the right-handed CT. Notice the small holes scattered throughout the lung parenchyma. Let's zoom in on a particular area for a closer look. Notice how there are small black dots or lucencies within the lung parenchyma. This represents areas of lung destruction, emphysema, identified by these black circles. This pattern of small lucencies occupying the central aspects of the secondary pulmonary lobule is known as central-lobular emphysema. This is most commonly seen in the upper lobes and is classically associated with smoking. Another distinct pattern of emphysema is paraseptal emphysema, where the emphysematous spaces are seen in the outer edges of the lung, as seen in this image on the right. This pattern is also most commonly seen in the upper lung zones. Again, notice the peripheral lucencies within the lung parenchyma out towards the edges of the lung. The last type of emphysema is known as panlobular emphysema, that is affecting the entirety of the secondary pulmonary lobule. This type of emphysema may be difficult to identify initially as discrete holes within the lung, as they may not be readily identifiable. Seen here are areas of confluent lucency in the lower lung zones bilaterally. Notice how there is mass effect on the fissures from the lower lobe predominant emphysema, typical of panlobular disease. Also, this disease, which can be seen in smokers, has been classically associated with alpha-1 antitrypsin. This leads to a relative increase in elastases, resulting in lung destruction. Because elastases are delivered to the lung via circulation and blood flow is greatest at the lung bases, it stands to reason that panlobular emphysema is a lower lobe predominant disease. Emphysema on chest X-ray may be difficult to see. Clues include increased lung volumes or hyperinflation, as well as areas of increased lucency as noted in the upper lung zone seen on this chest X-ray image on the right. Also notice how there is an absence of vascularity seen within the upper lung zones compared to the lower lung zones. This is the result of lung destruction from the emphysema. Emphysema in the upper lung zones is typically central-lobular in distribution and is usually associated with smoking, as in this case. This is the inverse of the previous case. The lungs are again noted to be hyperinflated. However, lucency is seen mainly in the lower lung zones, and if we look at the vasculature, we notice that the vasculature in the lower lung zones is relatively less compared to that in the upper lung zones. This is the result of lower lung zone destruction representing panlobular emphysema in this patient with alpha-1 antitrypsin deficiency. Cysts also present as areas of rounded lucency within the lung parenchyma. However, they often have identifiable walls, in contrast to emphysema where the wall is not typically seen. Cysts can be single or multiple, as seen by these multiple orange arrows within the lung. Notice how the rounded lucencies within the lung parenchyma have identifiable walls. Sometimes this can be difficult to see and requires a closer inspection, so let's take a look at a cyst in the right middle lobe. There is a hole within the lung, but notice how this hole has an identifiable wall. The identifiable wall tells us that we're looking at a cyst rather than an emphysematous space. Let's compare and contrast a case of cystic lung disease seen on the left and central lobular emphysema seen on the right. Notice the holes on the right have clearly identifiable walls, whereas those on the left do not. The case on the left represented a cystic lung disease known as lymphangiomyomatosis, in short, LAM, and on the right, a smoker with central lobular emphysema. Some causes of cystic lung disease include lymphangiomyomatosis, pulmonary Langerhans cell histiocytosis, and lymphocytic interstitial pneumonia, also known as LIP. On the right is another case of lymphangiomyomatosis who presented with a pneumothorax. Notice the air outside the lung parenchyma on the right within the pleural space. This is the result of cyst rupture. A single small cyst or a couple cysts are not normal, though they have a relatively low likelihood of being clinically relevant and are sometimes mentioned in the reports, though usually not expanded upon. These may be the result of prior infection or trauma. A cavity, on the other hand, compared to a cyst, is the result of a solid lesion or consolidation undergoing necrosis and then cavitation, unlike cysts, which may develop on their own. The walls of cavities, in comparison to cysts, tend to be thicker, usually measuring greater than 4 to 5 millimeters, and sometimes can be irregular or nodular, particularly if the cause is malignant. Like cysts, cavities can be single or multiple. On the right-handed CT image, we can see a solid opacity with central lucency representing an area of necrosis or cavitation from a squamous cell lung cancer. This is an example of a patient with both solid nodules and cavities. This patient had a history of colon cancer and was diagnosed with pulmonary metastatic disease. On chest X-ray, cavitation can be easily missed even if the lungs are carefully scrutinized. In this case, we can see that there are extensive areas of patchy consolidation in the upper lung zones bilaterally. This patient had a history of staphylococcal pneumonia. However, notice that there are some areas of lucency which demonstrate air fluid levels reflecting areas of cavitation. This patient was subsequently diagnosed as having a necrotizing pneumonia from a MRSA infection. Causes of cavities are multiple, including cancer, such as metastasis or even a primary lung cancer, particularly squamous cell carcinomas. Some infections can do this. We can see with necrotizing pneumonia, septic emboli, as well as pulmonary abscesses, an example of a pulmonary abscess seen on the right, as well as some inflammatory conditions such as granulomatosis with polyangiitis, a type of vasculitis formerly known as Wegener's, as well as rheumatoid nodules. Honeycombing is defined as a single row or stack of cysts, usually less than 1 centimeter in size, which abut the pleura. Honeycombing is usually the end result of severe lung fibrosis and may indicate a worse prognosis in some clinical scenarios. Seen on the right-handed CT image are rows and stacks of subpleural cysts, seen predominantly at both lung bases in this patient with idiopathic pulmonary fibrosis known as IPF. Let's zoom in on an area to take a closer look. Notice how we have cystic lucencies with identifiable walls. These each measure less than 1 centimeter in size. The wall appears smooth. They touch the pleural edge and they're stacked one on top of the other. Honeycombing should not occur in the central aspects of the lung without contacting the pleura. Pleural contact should be present to identify this finding. Mosaic attenuation in general terms means subtle areas of both lucent and dense lung. Technically, mosaic attenuation does not imply which portions of the lung is abnormal. That is it the dense lung abnormal, representing ground glass opacity, or is it the lucent lung, which appears lucent because the vessels are too small in size? They are oligemic. When the vessels are too small in size, we call this mosaic perfusion. Often mosaic perfusion and mosaic attenuation, these terms are used interchangeably. An example of mosaic perfusion is seen on the right. Notice how there is both dense and lucent lung. However, note how the vessels are smaller in size and appear less numerous in the lucent lung when compared to the denser lung. This implies that the lucent lung is abnormal and reflects mosaic perfusion. Small vessels and mosaic perfusion can be caused by both vascular obstruction, as can be seen with chronic emboli, or with air trapping. Air trapping results in small vessels due to hypoxic vasoconstriction, where the lungs shunt blood away from air-trapped lung parenchyma. Both vascular obstruction and air trapping result in mosaic perfusion, small vessels within the lung parenchyma. One way we can attempt to differentiate them is to perform inspiratory as well as expiratory phase imaging. Notice the shape of the trachea during inspiration versus expiration. The wall is bowed inward when breathing out. Also notice how the most of the lung becomes more dense or white during expiration. This makes sense. As you blow air out, the lung becomes partially atelectatic. However, also note how some areas during expiration remained lucent. These areas represent mosaic perfusion from air trapping. This was brought out during expiratory phase imaging. Now let's discuss some signs that involve lucencies. On chest x-rays on the right, notice how there is a cystic lucency at the right lung apex. However, did you notice that inside this cavity is a round, solid lesion? This is what's known as a monad sign. This typically indicates a fungus ball growing inside a cyst or cavity within the lung parenchyma. The cavity is typically the result of some prior insult in the lung, perhaps an old TB infection, which then serves as a petri dish to allow the fungus to grow inside of it. Interestingly, the fungus ball is not attached to the chest, to the cavity itself, and can rattle if shook or change locations depending on patient positioning. The monad sign is different than the air crescent sign. The first image on the left demonstrates a sign we've already discussed, known as the halo sign. This patient was neutropenic and febrile and had an infection with angioinvasive aspergillosis. Following normalization of neutropenia, the lung began to heal. The infarcted portion of the lung caused by the infection begins to retract. Notice how we have this nodule that's kind of retracting away from the edge of the wall. Because it's retracting away from the edge of the wall, this leaves us with a crescent of air surrounding it. This represents the air crescent sign. The air crescent sign indicates healing. This is an example of angioinvasive aspergillosis, demonstrating evolutionary change, the halo sign indicating active infection, and then the air crescent sign, a manifestation of healing and rebounding of the neutropenia. On the right is the example of a head cheese sign where there's a combination of abnormally lucent lung, we see here, abnormally dense lung, which we can see here representing ground glass opacity, as well as areas of intermixed normal lung. That is, we're seeing areas of abnormally lucent lung, abnormally dense lung, and normal lung intermixed. The heterogeneous appearance with multiple different densities has been likened to head cheese, an apparent delicacy made from portions of pig head placed in a jelly, something I heard is good, but will never try. Common causes for the head cheese sign, which is a combination of ground glass opacity and air trapping, are hypersensitivity pneumonitis, and some infections, particularly viral infections and mycoplasma. In conclusion, correctly describing opacities and lucencies is paramount in formulating an accurate report and developing a differential diagnosis. Differential diagnoses, which we had briefly discussed in addition to some helpful signs. This lecture was a composite of common terms used in chest imaging, though only a fraction of what there is to learn. For additional details, please see David Hansel's paper regarding a glossary of terms for thoracic imaging, where the definition of these terms for this lecture were obtained. Thank you for your time. If there's any questions, please feel free to email me.